Доброго вечора, українські радіаційні онкологи. Слава Україні! Дуже дякуємо, що приєдналися до Case Review with ASTRO Experts для України. Today we have a session on sarcoma, and our US speaker is Dr. Meng Welliver. She is a radiation oncologist at Mayo Clinic, and she is a disease group lead for sarcoma at Mayo Clinic. She completed her residency training, radiation oncology from University of Pennsylvania in 2011, and she's currently a committee member for ASTRO Education Committee and ASTRO International Committee. Dr. Welliver is also serving as the oral board examiner for hematologic malignancy. Thank you for joining us today and preparing the lecture for Ukrainian radiation oncologists. Welcome. And our Ukrainian speaker is Dr. Sofia Zaluska. Dr. Zaluska is a radiation oncologist at Lviv Regional Oncology Treatment and Diagnostic Center. She graduated from Lviv Medical University in 2020. And in 2022, she completed a specialization in radiation therapy at Shuberg National Medical Academy. And in 2023 and in 2024, she participated in 2 observerships abroad organized by Help Ukraine Group, one at Stanford with us here and another one at Northwestern University in Chicago. Thank you so much, Dr. Zaluska, for joining us today and preparing the cases for Ukraine and questions. So we are really eager to start and learn from you on radiotherapy for sarcoma. Dr. Welliver, without further ado, the podium is yours. If you can please put it in presentation mode, change the display setting.
Okay.
Perfect. Yes,
Okay.
that's great.
All right. Thank you. Sorry, I was changing the screens. Thank you so much for that kind introduction. It was my pleasure to be here and sharing experiences of treating sarcoma with all of you. So as Natalia introduced, I'm a radiation oncologist and I treat sarcoma and lung cancer. So today we're going to focus on soft tissue sarcoma. So just briefly, this is our outline, talk a little bit about epidemiology, presentation, treatment principles, and practicality. So first of all, sarcoma is a rare disease. It's about 1% of all adult malignancy, so it's very rare, about 13,000 cases per year in the United States. So comparing to lung cancer or breast cancer or prostate cancer is maybe about 10% of all of that. So, but it's also very heterogeneous. So there are many, many subtypes of sarcoma. They all arise from mesenchymal tissue. So if you see a pathology term of leiomyosarcoma, it's derived from smooth muscle. Rhabdomyosarcoma from skeletal muscle, and so on and so forth. So that's really representing the origin of the cancer. So most sarcomas are, presented in lower extremity. So extremity sarcoma is probably most common. So 46% will present in the lower extremity and 13% in the upper extremity. Some sarcoma would present in the head neck area. So it really can be anywhere, but most of them will rise from the lower extremity. 95% of the soft tissue sarcoma has no known cause. So, unlike lung cancer, smoking is part of the etiology of lung cancer, but sarcoma really, we don't know why. There's, someone developed sarcoma, but there are some genetic associations. For instance, NF1 is associated with MPNST. And Li-Fraumeni syndrome, which is a P53 mutated in germline, they could also cause sarcoma. Probably most relevant pathogenesis is related to chemical exposure as well as prior radiation. So if someone had radiation um, with a latency of about 3 to 5 years, they could develop sarcoma. Um, so we touched briefly on classification in sarcoma, but it's interesting you see that there's liposarcoma, there's synovial sarcoma, so it represents the normal tissue they mimic, and it's not the cell of origin, which is important in how we treat this disease. Um, and there's poor concordance of pathology. So one of the things I wanted to convey to people is that if you don't think this where you're treating doesn't fit, it's you should question your pathology because because this is so rare, a lot of the pathologists never really see sarcoma. And, it's very, very common. I think it's a good habit to get second opinion, and that could make a difference in how you treat this patient. So some sarcoma tend to locally progress, like desmoid tumor, like atypical lipomatous tumor. But some sarcoma, usually high grade, tend to metastasize, like these um, sarcomas. So specific etiology, a specific pathology like UPS, undifferentiated pleomorphic sarcoma tend to metastasize. And it also can local recur. So these sarcoma tend to be more aggressive and could go to, distant sites, which is usually the lungs, and then also the, locally recur. And these specifically synovial sarcoma, clear cell sarcoma, angiosarcoma, rhabdomyosarcoma, epithelioid cancers, it was a name of scare. They tend to go to the lymph nodes. So when we see someone with sarcoma, often they present as an asymptomatic soft tissue mass, and they it's very, very important to establish tissue diagnosis. And one thing I want to emphasize is the use of core biopsy. FNA is not sufficient because just like lymphoma, I think you'll have lymphoma lecture later on. If you don't get sufficient tissue, often they could have very different diagnosis. As we mentioned before, pathology is very important. So if you, the when you have sufficient tissue, then you may have more accurate diagnosis. So core biopsy or incisional biopsy is usually when we test in our tests for residents and for junior attendings is the answer, and FNA is the wrong answer. So with that, so you want to have a core biopsy to get tissue, and then you need to also evaluate the primary. And then the way to evaluate that is the MRI. You want to have T1 post-contrast to establish the primary disease, how big it is. And then T2 will evaluate tumor edema, and that would also help you determine your treatment volume. And you also want to get a CT scan in order to get your CT scan of the chest to evaluate for metastatic disease. For specific tissue diagnosis like myxoid liposarcoma, because they tend to have multifocal disease, now NCCN guideline recommend whole body MRI in order to have a more accurate staging for this disease. So sarcoma staging, T1 less than 5 centimeters, T2 between 5 and 10, T3 10 to 15, T4 15%. Very straightforward. But it's interesting that, and it's important, grading plays a role in sarcoma staging. So if you have someone with a grade 1 disease, they may have a very large tumor, but it's still stage 1B. But if they have a grade 3, they could have a T1 that's already stage 2. Does that make sense? So grading, I think, is one of the only cancers that you know the grade of the tumor, how aggressive it is, determines the overall staging. Grading 2 to 3, T1 could be 2. So the new staging guidelines include the separate area for sarcomas. Head neck sarcoma has its own staging. As you could see, that head neck area is smaller, so the 5, 10, 15 centimeters is not going to apply. So here T1 is less, somewhat, a tumor less or equal to 2 centimeters, whereas T2 is between 2 and 4. Similarly, soft tissue sarcoma involving the visceral organs like abdomen, pelvis, and retroperitoneum, they have their own staging as well. So question number 1, a patient came to your office complaining about a mass in the left arm. It's about 5 centimeters in size. It's painless and it's been growing for a year. What would you like to do in order to establish the workup? You want to, excise the lesion because you think it's a benign disease. You could get advanced imaging. You can get fine needle biopsy, or you can just watch it, say, come back in 3 months. We didn't get any answer. You want to just move forward?
So you don't see the pop-up, the
I see the
polling,
pop-up.
and people are answering. So
Oh, people are still answering.
there's
Okay, great.
78, now 80% answered.
Okay, great. Awesome.
Yeah, so let me finish the polling and share results. So what we see here is answer C was the most popular, 56% answered C,
Yeah.
33% answered B, and 10% answered A. Nobody answered observe.
Observation. Good.
Mhm.
Very good. So it's a little tricky, this question. I think the next thing to do is to get advanced imaging, so like MRI, because typically biopsy would be correct, but as we mentioned, fine needle biopsy is not is sufficient. So it's a little bit of a tricky question. Sorry.
So
It should
it's
be
supposed to be core biopsy, right?
yeah, of course, supposed to be a core and incisional biopsy for this one. Yeah.
Okay,
Yeah.
stop sharing. So you can close that window.
Okay, it went away by itself. Oh, okay. Okay, so prognostic factors. What would be important for the survival? When you see a patient, they will ask, Doc, how long am I going to live when I have this cancer? So you can tell them if you have stage 1 disease, the chance for them to be alive after 5 years is 90%, which is very good. But if they have stage 3 disease, that changed to 56%. So remember, they don't have to have a big tumor in order to be stage 3. They could have a high grade, grade 3, and then a 10 centimeter tumor, and that would be stage 3. So, so you see that this, overall survival, disease-free survival, it's really related to the stage, which is not surprising. Now, if someone has a high grade, their survival is worse, as you can see in this diagram. Low grade, long survival, intermediate grade, and high grade is here. Also, if you have a large tumor, they tend to have worse freedom from distant metastasis compared to a smaller tumor, which is all making sense, right? So what about local control? Local control, we haven't talked about treatment. You can imagine treatment is surgery and radiotherapy. So if you have someone with surgery, if they have a negative margin, understandably, they're going to have better local control than the positive margin. So it's actually the most important part for local control is the margin status. Um, also the location is important. If someone has a tumor in the extremity or superficial trunk, they may have much better local control than head neck tumor in the head neck area. And it's purely because in the head neck area, it's much harder to get a white margin resection, just, for the nature of the location of the disease. So local control worsened by positive or unknown margins, and then head neck or deep trunk site. Now, if the patient has present to you as a primary sarcoma, and they will have better local control than the recurrent ones. And if patient is younger, less than 64, then their local control will be better as well. So now this is a summary of prognostic factors. For local recurrence, those factors really is, resection margin status, whether it's positive or not, whether it's a head neck location, whether it's age, advanced age or not, or it's a recurrent tumor. So you can see that that's different from, say, patients may have risk for the metastatic disease, and that's related to the grade, related to the size of the tumor, and histology. Some histology tend to metastasize and others don't. So that kind of makes sense, right? Like resection margin is related to local recurrence, whereas grade and size of the tumor is related to the metastatic disease recurrence rate. So question number 2, what is the most important prognostic factors after surgery for local control? We just talked about that.
Okay, we have 80% participants participating in the poll. I'm ending.
Okay,
And what we see is 65% answered margin status,
excellent. Good job.
and
Yeah.
23% tumor grade, and only 5 and 7% answer A and D.
Okay. So the grade is also important for metastatic um, development potential, but margin status is most important for local control. Yeah, very good.
Great.
So we'll continue. So treatment. So we're not going to touch on chemotherapy at all. I think our audience here is all radiation oncology. So, if you talk about sarcoma, we have to talk about surgery because that's the mainstay of treatment. Um, when when we talk about surgery, there is surgical excision with negative margins. That's very important. There's 3 kind of surgeries: white local excision, there is re-excision after unplanned excision. So often you see a patient, if you're a surgeon, they got, patient, went to their GP and they said, oh, they thought it was benign tumor and it was excised. So that basically that's what you got, and then you have to re-excise that. So it's a re-excision. And then if a tumor is really large and then you can't really do a reasonable white local excision, then you have to perform amputation. So that's essentially 3 different type of surgery. And radiation, you can give radiation before surgery, which is preoperative radiation. You can give radiation after surgery, which is postoperative. You can have boost. So historically, sarcoma is managed by amputation because surgeons recognized that if you just cut it out, then it keeps coming back. So attempt at limited surgery, local control can be as high as 30 to 50%. Essentially, 40% of, less than half the patient will come back within 6 months. So the standard before the 80s was actually amputation. Now, NCI did this first trial. They basically tested the hypothesis of if you add radiotherapy, can you keep the limb? So they randomized 43 patients with amputation versus wide local excision plus radiotherapy. Radiotherapy is done post-operative. They also got chemotherapy. And they show that, while amputation patient who underwent amputation have 100% local control, that wide local excision with radiotherapy also achieved reasonable local control. You can't compete with amputation, right? And then their overall survival, which is important, is the same. So that established the role of radiotherapy, really, because we know if you don't have radiotherapy, then the wide local excision is not sufficient. So this is a subsequent study where they looked at, they had surgery alone, limb sparing surgery, and then limb sparing surgery with radiotherapy. And they saw that without radiotherapy, the local control is much, much worse. You can see on this graph, even though the overall survival was similar. So, with radiotherapy, you can keep the limb. You don't necessarily live longer. So it really allows for limb salvage therapy. So then what about the question of pre-op versus post-op? So sarcoma, team should involve pathology, surgeon, medical oncology, and radiation oncology. So one of the important factors that, if you want to be part of the decision making, you have to see the patient before they actually went to surgery. So if there is a multi-D discussion going on, whether it's a tumor board, whether it's a multi-D clinic, where this decision can be a joint decision, then we could then, talk about which is better, pre versus post. I mean, if you see patients only after surgery is done, of course, we don't, as radiation oncology, we can't really make that decision. So what's the advantage of pre-op radiation? So radiation before surgery, you don't need as high of a dose. So lower dose, smaller target because you only have to target the tumor itself plus a margin. And the response may allow resection, different kind of resection. And the radiation is done at intact blood supply. So there's no hypoxia involved. Post-op advantage, you already know the pathology, whether it's high grade, low grade, or whatever, and you know the margin. So that's the advantage of post-op radiotherapy. And also, if the patient really needs surgery right away, there's no delay in that. So if, that's certain situations, post-op is still better because of that. So so is there any study to evaluate that? Yeah, the answer is yes. So there's a Canadian study that showed to look at the difference between pre-op versus post-op. So there is they randomized 190 patients with pre-op versus post-op, and they stratified the patient with tumor size. And the endpoint is wound complication, secondary operations, disease outcomes like local control, metastases, and so forth. So what they saw was that, you know, uh, the first of all, let's see the surgery and radiation. Surgery and radiation is 3 to 6 weeks apart, and margins around GTV is 5 centimeter proximal and distal, and 2 centimeter radial. Now, this is before 3D and IMRT, where the volume-based radiation was done. So this is purely by margin by distance of ports. So they have the basically use the tumor volume plus and minus with the borders basically. So let's see. And they saw that with pre-op radiation, they saw higher rate of wound complication. So 35% for pre-op. For post-op, it was only 17%. And then those patients who had lower leg, sarcoma tend to have more complications of the wound. So if they have a upper arm or upper leg, it's not that different. I mean, upper arm or lower arm, it's not different. But then if you have an upper leg and lower leg, so lower extremity tend to have wound complication. No difference in local control pre-op versus post-op, and no difference in distance, metastasis, or overall survival. Um, well, there's a little bit difference when the subsequent analysis is done. So the pre-op is better. Pre-op wins for overall survival, which they can't really answer why that is because the local control and distance metastasis is the same. And this was actually persisted after, the reanalysis. Overall survival still favors the when they reanalyze the data later on, the overall survival becomes the same. So basically, the disease outcome is the same. So then, who should get pre-op? Who should get post-op? So they actually look at the trial results again, after 2 years, and they saw that baseline patients, there are more patients with bigger tumors for pre-op. So they're a little bit worse compared to the post-op cohort. Now, it's not completely balanced. And then they also saw that patients with post-op therapy had more fibrosis and more joint stiffness. So, it's because when they run this, they saw that subcutaneous fibrosis is worse with post-op, joint stiffness is worse with post-op, and edema is worse with post-op. So the field size is correlated with post-op, despite the pre-op had bigger tumors. So their conclusion is that the disease control is unaffected by choice. And then if you don't have to feel bad when you have to give patients post-op radiotherapy, but pre-op has greater risk for acute complications, whereas post-op correlated with worse late toxicity. And this is supported by other studies. How do we decide then? So pre-op generally favored when possible, given that the disease control being equal, function becomes important. Acute toxicity like wound complication, it will be normalized after a year. So it's not long lasting, it's temporary, whereas the late toxicity with post-op is likely permanent. But they're not really like life and death toxicity. Is the joint stiffness, they're more fibrotic tissue. So and then you can, you can counsel the patient based on those factors. Post-op is appropriate if you need to do prompt local surgical palliation. The patient really needs to get surgery right away. You want them to do surgery. So here we have the third question. So what is not an advantage of pre-op radiotherapy? Less long-term side effects, such as joint stiffness, less major wound complication, lower dose, and more defined target. So this is a negative question here. So choose the one that's incorrect. I noticed that this one was not oh no, sorry. Yeah, I don't see the pop-up. The pop-up had a
Oh,
translation, right?
Yes,
Thank you
yes.
for translating that.
Yeah, we see the translation.
Okay.
Yeah, okay. 81%, 83% participated. I'm ending the poll and sharing the results. So we have, it's a bit of a split answer.
Mhm.
29% answered B and 29% answered C, 24% answered A, and 17% answered D.
Yeah. So A and C and D, they're all the advantage of pre-op. So I think if you didn't think of that as a negative question, sorry, this is, shouldn't be. I don't even know whether they allow those negative questions. So it's a not advantage. So what is bad? What's bad about pre-op radiation? So
Mhm.
what's good about radiation is less long-term side effects and lower dose and more defined targets. What's not good about pre-op radiation is the
One
major
complication.
good complication. So B is correct.
Mhm.
Yeah. Okay, let's move on. So treatment practicalities. So if you see a patient who is ready for radiation, what do you do? So simulation. If we talk about preoperative radiation, we usually, or even post-op, you want to do preferably treatment position MRI. So that would allow your CT and MRI um, abnormalities all kind of, exact in the same position. So, when you fuse the MRI and then the CT, then you get exact the same orientation, which is helpful if you have that, if that's available to you. And you want to image one joint above below for extremity lesions because otherwise it's hard to match when you are in the treatment machine. You want to bolus this or wire the scar for post-op because that's important. That area needs to be covered. So limbs move a lot and also rotate a lot. So that's really is actually quite difficult. So you want to make sure to have a most stable position. You want to separate the skin folds. You want to bend away or move the contralateral limb out of the way by frog the leg or make it elevate the contralateral leg or whatever. Um, when it's a proximal thigh, then it's a male patient, you may think about protecting their testicles by using clamshell or move it out of the way. What if it's a area that's where very wobbly and has a lot of fat? You want to use a bigger margin for that. So for instance, if someone with a elbow lesion, like here, that could rotate, can move. So we actually use a extremity mask to fix their distal part. By having this extremity mask, this elbow become very stable. And similarly, if you want to treat the wrist lesion, same thing, use the extremity mask. So for someone with a calf lesion or knee, we also use the extremity mask to stabilize their foot. So by fixate the distal end, the proximal part where you need to treat is more stable. Over 5-6 weeks, right? Because you want to make sure that's it's very reproducible. So sarcoma growth patterns, this is an axial slice of, a lesion in the muscle. So what happens is that it grows really rapidly within that compartment, but then, there's too much pressure within the fascia. So then they just move distally, longitudinally. So they grow along the less resistance, general along the muscle fibers. So, um, and then also when you see a capsule, it's a pseudocapsule. It's a compression zone. So there's tumor beyond that capsule. So that's also very important. So for instance, here, the tumor is here. The you know the patient may have satellite tumor outside of this so-called capsule here. And this area that's in yellow, it's reactive zone. So that would, show you the T2 image will show you where the reactive zone is. The tumor don't usually, go through the fascia into a different, to go to this muscle. But then this area you have to cover a little bit in order to make sure that you don't miss that. Um, and it's gonna spread further along the muscle fiber rather than against horizontally against super the muscle fiber. So we typically use MRI to identify the region. So we use T1 plus contrast to identify the lesion itself. That you could see that right here. And then um, more superiorly, you could see, the areas that's, still enhancing that you want to add. So the so-called the tail of the lesion. And then the T2 will be the reactive zone that you want to cover within your CTV. So GTV will be T1 plus contrast, and CTV would be the T2 plus the margin, after your CTV. So the dose is 50 gray in 25 fractions, and in GTV, it's based on T1 plus T1 post contrast, and CTV is with this margin, GTV plus 3 centimeters, sup inf, and then 1.5 cm radial. And sometimes, if you're worried about margin not long enough, they will advocate for 4 centimeters. Say someone with a big long tail, myxofibrous sarcoma, for instance, and then or you want to have a bigger margin. So this is all pre-op, of course, so you actually could see the tumor. PTV minimum is 0.5 cm. So sometimes when we don't have reliable setup, we want to make it long, bigger. So for post-op, we use basically a sequential boost often. The first course, when you target the bigger area, it's 45 gray to 50 gray, and then cone down to a smaller area to 63 to 68 based on the margin status. So 68 if you have positive margins. And then, this is data from Dr. Delaney from Mass General. You know that if the dose is less than 64 gray, 5-year local control is only 66% with tumors with positive margin. So if you have gross unresectable tumor, you want to take the dose to over 70 gray. So post-op contouring, you want to, first contour will be the tumor beds. You want to know where the tumor was, based on the pre-operative imaging. Hopefully you have that. And then, the entire tumor bed is your CTV. The CTV2 really is basically that's the minimal. And the CTV1 is basically, the tumor bed plus 4 centimeter longitudinally and 2 cm radial. So that's why we talked about post-op having a bigger field, because you have to treat the whole tumor bed plus a margin. And that's your CTV1, which is the lower dose. And then you boost the higher dose with the tumor bed with 2 cm uniformal expansion to 63 to 68 gray. Sometimes you could have, boost for residual disease to over 68 gray if it's R2 resection. So toxicity after radiation, one of the important one is bone fractures. So, Princess Margaret, University of Toronto, did this study, and they saw that if the tumor dose, when you have a higher dose, you may have up to 7% fracture rates after 5 years. So, things that are related to that is periosteal stripping from surgery, and then also the dose to the bone. So dosimetrically, we want to make sure that our dose to the bone is kept under these things. So B50, the 50% of the bone receiving 50 gray is less than 50%. So the bone is contoured 2 cm sup and in to the PTV. So um, should we treat all sarcoma the same way? No, the answer is no, that we need to start incorporating biology to sarcoma. One of the recent studies is a Do-Re-Mi study where they looked at myxoid liposarcoma. So this disease, it was being observed to be radiosensitive compared to other sarcomas. So myxoid liposarcoma, clinically, they saw that is more sensitive, and a lot of times you could see past CR. So then in Netherlands, they did this study where they randomized patients, non-randomized study, phase 2 study. They tested the hypothesis that if you reduce the dose from 50 gray to 36 gray before surgery, whether that would give you the same outcome. And the answer is yes, with the first reports. I don't know whether they will have additional reports with long-term data. So this is actually, 60 months. You could see that the disease-free survival is pretty high. It's close to 90%, and even after 60 months, it's still over 80%. This is with 36 gray. So, in our institution, um, we also use a lower dose for myxoid liposarcoma. Not to be, confused with myxofibrosarcoma, which is a different entity, and that one is actually more radio-resistant or equally resistant. So it's myxoid liposarcoma. So, and the second question is about hypofractionation that has been, explored by many institutions in the U.S. And in Europe. So we know sarcoma has a lower alpha beta ratio that treatment outcome should theoretically favor hypofractionation. So, there are many trials that attempted this. The European trial initially was done using 25 gray in 5 fractions. And they saw that with this study, they have lower local control is 81% at 3 years. So, we usually want to have a local control over 90%. So this is a little shy of that. And then this is UCLA study when they use 30 gray in 5 fraction, and you can see the local control is better. We and MD Anderson had done a study looking at hypofractionation, but moderate hypofractionation with 15 fractions, so 3 weeks. And then we use 42.75 pre-op for that. All of these are pre-op, not post-op. So as you could see that if this is a summary of all of the hypofractionation study, the wound complication is listed here, and local control is listed here. So the 15 fraction hypofractionation study is this one, where 42.75 gray in 15 fractions was used. It's 93% local control, overall survival 91%. As you can see, it's much better than the 25 in 5 fractions. But when you look at it, EQD2 is only 40 gray for this, right? So this study clearly their biologic dose is a little bit on the lower side. So that could be the reason why the local control is not good, and it's not because of its 5 fraction. So those has not been standardized yet for hypofractionation. The standard currently is still 50 gray in 25 fractions, but I think it's going to become very soon a standard. So MD Anderson published their long-term result for their 15 fraction treatments, and the local regional failure rate, local control rate is 93% at 4 years, which is great. The bone fracture rate is a little bit high on the 4% side, but it's, there are only 100 patients, so I don't know whether it's a fluke or where there are dose constraints having problems, but but right now we think of this fractionation being fairly similar to the current 25 5-week treatments. So what about immunotherapy? SARC-32 just published late last year where they utilize PD-1 blockade, pembrolizumab with radiotherapy before surgery, and they saw that there's a higher distant metastasis control with the addition of PD-1 inhibition. Disease-free survival was better. The distance disease-free survival is also better with the immunotherapy group, whereas there's no difference in local regional failure group, which is, understandable. Immunotherapy playing a role in the distant metastasis, right? So of note, this one was only including UPS and D-diff liposarcoma. So not all the sarcomas are sensitive to PD-1 inhibition. So right now because this is a phase 2 study, it's not FDA approved. We still don't add PD-1 inhibition, but this is what's in the horizon in the future. So question number 4, which of the following statement is correct? Myxofibrosarcoma is sensitive to radiotherapy. Therefore, a lower dose is required. Myxoid liposarcoma is sensitive to radiotherapy, therefore, a lower dose is required. And then 3, checkpoint inhibition is effective for all sarcoma subtypes. Soft tissue sarcoma doesn't metastasize to any lymph nodes. So here we have it. I could see the response right here. That's great.
Nice.
Yeah. So most people got this correct. Myxoid
We'll
lipo.
wait for
Oh, sorry.
80%. Yeah,
Okay, sorry.
no worries. So it's still 60%. But we could see the nice trend, right? They're
Yeah,
answering
we can see the
correctly.
right trend.
Yeah,
Everybody is paying attention.
yeah, good
Yeah,
job.
thank you. Good job.
So waiting for 80%. Few more votes. Okay, ending the poll, sharing results. So majority, 47% answered B.
Yeah, that's correct
That's
answer.
correct answer. And then 22% answered C, and 18% A, 13% D.
Yeah. C is partially correct. It's effective for some sarcoma subtypes, not all.
Mhm.
And A is partially correct because it has a myxo in it, but it's a trick question. Like myxoid liposarcoma is different from myxofibrosarcoma. Yeah.
Mhm. Okay,
Yeah. So
that's
questions.
great.
That's it.
Yeah, thank you so much. That was a really nice, great overview. It's a complex disease, right? 100 diseases in it, and it's
Yeah.
difficult to treat it. But that was a great overview. And now we invite Dr. Zaluska, and she will share some of the cases from Lviv Regional Cancer Center.
Great.
Yes, so good evening, dear colleagues. To begin with, I would like to thank to Natalia Kovalchuk and Help Ukraine Group for this wonderful opportunity and for creating this course. And also, I would like to thank Dr. Welliver for this wonderful lecture. It was very informative and interesting. Thank you so much. And now I would like to present 2 cases from our hospital. The first case is 61-year-old female with PT4 M0 stage 3 synovial sarcoma of the left thigh. MRI shows us a volumetric formation measuring by 167 by 84, 193 millimeter was visualized in the region of the long head of the biceps femoral muscles of the left thigh. This patient undergo surgical treatment, radical removal of the left femur tumor with local tissue plastic reconstruction. And histology showed us synovial sarcoma grade 2 with clear R1 resection margins. And next step is our treatment plan. We plan adjuvant radiation therapy course with total dose 50 gray in 25 fraction, plus a boost of the in dose 10 gray in 5 fraction, delivered 5 times a week. Technique, we use vertical modulated arc therapy with daily imaging, cone beam CT. For simulation, the patient was simulated in a feet first supine position using vacuum matrices for immobilization to ensure the accurate positioning and our contours. So we create GTV based on the fusion of preoperative MRI and postoperative CT. Postoperative GTV is created to help us with creation of CTV. Our CTV 50 gray is GTV proximally and distantly plus 4 centimeters and radially GTV plus 1.5 centimeter, limited by muscle, excluding skin and bone tissue. Our wood CTV 60 gray is GTV proximally in distantly plus 2 centimeters and radially GTV plus 1.5 centimeters, limited by muscle and also excluding skin and bone tissue. PTV equals CTV plus 5 millimeter. And also we crop inside the body, PTV inside according to the skin to avoid skin irradiation. So now the questions. How would you recommend treating this patient? When administering adjuvant irradiation to the area such as lower leg or forearm, can we disregard standard margin in the order to preserve blood vessels? Is it acceptable to apply lower doses when irradiating histologically highly sensitive types of sarcoma, such as myxoid liposarcoma? And what risk factors do we focus on when determining the boost dose in adjuvant treatment?
Yeah, those are good questions. And first of all, I think the case was great, and you know, and your volume and dose, it was all very appropriate. It's kind of hard to know
Thank you.
exactly where the surgical bed is. So then the pre-op imaging was helpful, that you know, the fact that you were able to obtain that and then you know, fuse with your current imaging, that's great. I think sometimes if the surgeon help you out by leaving some clips in the surgical cavity, or you can see something remaining so you know where the surgical bed ends, usually it's bigger, right? Because they have to cut with a big margin, hopefully. um, Usually it's much bigger than the pre-op GTV. And then from that, you expand 4 centimeters supium. So then, you know, I couldn't really tell from the CT that, you know, there's doesn't seem to be a lot of changes in tissue, so I can't quite tell where the surgical bed ends. So I think that would be the most, you know, things that for people to pay attention is like the surgical bed is really your CTV1. That you expand from that. It's usually bigger than the pre-op volume as well. So the second question, about blood vessel, we don't typically preserve it. When you give conventional fractionated radiation, the blood vessel usually are doing fine. So you don't have to carve around it. But we carve around the bone because we know the tumor doesn't really goes into it. Um, but um, but the blood vessel, we don't have to. You don't have to have special margins about that. Um, yeah, and the third question is a good one. I don't know whether there is a equivalent reduction of dose for myxoid liposarcoma for post-op. Theoretically, you could, right? You just back calculate how much. Um, but I would also be careful with that because myxoid liposarcoma tend to have satellite lesions and tend to metastasize. So, after surgery, it's even more important to identify possible satellite lesions from the spill. The surgeon may spill some and then it will just grow. So it's often the volume could be larger, and then I would make sure that all surrounding areas, like say the tumor is in the thigh, we want to MRI the thigh and pelvis and the lower leg just to make sure that all of the areas is in your surveillance, that you include all the possible abnormalities for satellite lesions. Um, Myxoid liposarcoma is tricky because even though it's really responsive to radiotherapy, it tends to metastasize early. So, risk factors we focus on determining the boost dose. I think it's really just the margin. I would just purely go by the margin. If it's R0 resection, like your case, 60 gray is appropriate. If you want to make it shorter, you could consider a simultaneous integrated boost instead of sequential boost. So basically apply a higher dose to the smaller margin, so then you can finish a little earlier. So in this, I think sometimes it's probably important just to make the machines more available to patients to have a shorter course. But yeah.
Thank you very much for answering.
Oh, of course. Thank you for the questions. Those were great questions and good case.
Thank you. So our next case number 2, is 25-year-old male with recurrent alveolar rhabdomyosarcoma of the left lower leg, PT1 and 0M0, stage 2. His medical history. In July 2023, MRI showed us volumetric intramuscular soft tissue mass in the left lower leg involving anterior tibia artery, fibular artery, veins, and deep fibular nerves. Same month, biopsy was preferred, and immunohistology showed us a confirmation of alveolar rhabdomyosarcoma. So he undergo 2 cycles of chemotherapy, doxorubicin, vincristine, cyclophosphamide, mesna, filgrastim. It resulted in a 40% regression, and after that he undergo a surgery, surgical removal of sarcoma of the left lower leg. And 1 year after, MRI showed us a recurrence in the posterior muscle group of the left lower leg, 39 per 49 per 37 millimeters. Follow-up CT of the chest, abdomen, and pelvis showed us no metastasis. And the same month, surgery was preferred, and surgical resection of the recurrent tumor was made. And histology shows us recurrence of alveolar rhabdomyosarcoma from rounds and clear cells, grade 2. And resection margins more than 5 millimeters, no tendon invasion, and biopsy finding tumor foci present more than 3 millimeters from the specific angle, so it's R1.
So question here, So the biopsy, this is biopsy of what?
It's histology after operation.
After the operation, I see.
Yes.
So it's just a histology.
Histology.
Yeah, they, let's see, can you go back one more? One more slide. Yeah, that's good. It's resection. Okay. Yeah, sounds good. Thank you. And then next slide. Okay.
And after that, our treatment plan is adjuvant treatment, radiotherapy to the tumor bed, total dose 50 gray, 2 gray per fraction plus a boost, 16 gray in 8 fraction, delivered 5 times a week. Technique VMAT with daily imaging, CBCT, CT simulation. The patient is simulated in a fit for supine position, lying on his back, using vacuum mattresses for immobilization. And now our contours. So our GTV is based on fusion of preoperative MRI and postoperative CT, and as well as surgical clips placed by surgeons this time. And our CTV 50 gray is proximally and distally GTV plus 4 centimeters, radially GTV plus 1.5 centimeters, limited by muscles. CTV 66 gray, boost CTV, proximally and distally GTV plus 2 centimeters, radially GTV plus 1.5 centimeters limited by muscles, and PTV is CTV plus 5 millimeters, and we crop inside skin to avoid irradiation of the skin. And our questions. How would you recommend treating this patient? What's the additional restriction in irradiating sarcomas in younger patients that are not present in older patients? What are the specific consideration for treating recurrent sarcoma? And does your approach to treat sarcomas patient differ if sarcoma was induced by prior radiation therapy?
Yeah, that's a very good question. So I would say the first of all, even though this is a 25-year-old patient, rhabdomyosarcoma is a pediatric sarcoma. I would still follow the pediatric protocol. So I would go to my pediatric colleagues and ask whether there's any current COG treatment guideline. You know, COG is the Society for the Pediatric group. So just like the other patient who's younger, but that's embryonal rhabdomyosarcoma. So then they said right now they have a COGD 9803, you know, so then they will have the biggest difference between that, the COG recommended protocol versus the adults is the chemotherapy use. The chemotherapy often is different. And, you know, you could argue 25 is not that different from 18-year-old, so that, or 17-year-old. So they will just use the same, more aggressive chemotherapy. Radiotherapy usually is the same. The difference for younger patients that's not present in older patients is the potential for secondary cancer is more just because they have much longer to live. So if you can for leg, you know, maybe not as much, but if it's a other location you want to think about using protons.
Ukraine does not have protons.
Yes.
You know, yeah,
Definitely.
yeah, right. So specific consideration for treating recurrent. Again, this is the biggest difference for a rhabdo would be chemotherapy being different. And then their dose, I think you mentioned in the past was what's the other dose? It was a 5580 or 55. Yeah, the dose is appropriate for this one. Alveolar rhabdo is resistant to radiation, so you wanted to treat just the same as the other sarcomas. Yeah.
So you did 50 and 66, right, Sophia?
Yes.
Yeah.
Yes.
Because it's R1.
Yeah.
That's the reason. It's still because of the margin. Yeah. Um, if my approach to sarcoma patients differ if the sarcoma is induced by prior radiation, actually,
Yes.
no, I still use radiation. Yeah. So even though it's induced by radiation, it still would respond to radiotherapy. That's a very good question. So
Oh, I see.
I actually treat a lot of patients with sarcoma that had breast treatments before. So often it's angiosarcoma, and we have a protocol here where they give chemotherapy and then chemoradiotherapy because angiosarcoma is really sensitive to Taxol. So we give radiation concurrent with Taxol followed by surgery. We still do everything before surgery. So yeah. So I think my biggest difference here would be probably thinking about pre-op rather than post-op. Um,
Oh, yeah, for sure.
yeah, yeah, yeah,
So, if you were to maybe assign percentage of patients that get pre-op at Mayo versus post-op for sarcoma, what would you say those numbers would be?
it would be 90%.
Pre-op,
Oh,
Yeah,
wow.
90% pre-op.
yeah. Yeah,
Okay.
it's because our surgeons are trained in institutions that they are very comfortable operating post-radiation patients.
Mm-hmm.
For extremity, for the spine, for in the abdomen, pelvis. So it really it's not radiation oncologist's fault, but it's the surgeons have to be comfortable. But you can educate your surgeons by participating in tumor board, basically seeing patients about the same time as they can they
Mm-hmm.
do, then that's really your only opportunity to do that. Yeah. And
I
then,
heard, yeah, I
yeah,
heard that Cleveland Clinic, they do the multi-D with the patient in the room.
yeah,
Do you do that
yeah.
at Mayo as well?
For certain disease group, for breast, we do that. And I
Okay.
think for head neck, they do. And then
Mm-hmm.
just for us, we have two separate hospitals. That's the biggest difference. That it's for sarcoma, the
Right.
surgeons operate at St. Mary's where we see
Yes,
patients.
yes, I remember. Mm-hmm.
And so it's a little bit hard to make it happening at the same time. But
Mm-hmm.
yeah, I think multi-D clinic is a great way to go, especially if most of your patients are not like metastatic patients who are gonna only get chemotherapy, for instance. And if you have a lot of patients like that, like lung cancer, then your multi-D clinic may not be as efficient because you'll have to skip a lot of patients that you don't see.
Mm.
But
Can
yeah,
you also comment maybe on switching to pre-op? Like you have to be very cognizant about timing of radiation, right? And surgery,
yeah,
so you have to be very coordinated. Like that can be
yeah.
an issue sometimes.
So after radiation, the surgery needs to be done between week 4 to week 8. You still have 4 weeks. So
Mm-hmm.
they wait for 4 weeks and then they do surgery. Beyond week 8, then they may get too fibrotic and it's hard to do surgery.
Right.
So there is a timing issue. But it's not like you have 1 week to choose. You have 4 weeks or 5 weeks because they can be as early as 3 weeks to operate. Um,
And which patients do you specifically choose not to do pre-op?
the patient had a prior radiation, for instance. I
Okay.
usually
Mm.
would just not add more fibrosis for our surgeon's
Right,
sake.
right.
And then this patient has, like, say, ulceration, their tumor is bursting open. They really need
Yes,
to go to surgery. And
right.
then, radiation could make edema worse and make symptom worse first before it gets better. So I would
Mhm.
I would recommend surgery first for that. We didn't talk about chemotherapy, and that's very, very variable among different institutions. In our institutions, we don't typically give pre-op chemotherapy, but a lot of institutions do.
Mm-hmm.
So, and it's usually talk about high-grade tumors, greater than 10 centimeter tumors or 8 centimeter tumors, but they get neoadjuvant chemotherapy, and then they do radiation and then do surgery. It's like three punch, 1, 2, 3 punch. But that is very variable among different institutions. Yeah. So
Thank you. So we have
yeah,
some questions in the chat
yeah.
from Dr. Taluja. Which margin do you use for postoperative head and neck sarcomas?
That's a really good question. Sorry, I don't treat head and neck sarcomas. So I would say, that's a hard one. I think 1 to 2 centimeters for CTV at least. It's really hard to do 4 centimeters, right? It's not possible. It's not likely to do 3 centimeters. But the tumors tend to be smaller because it's more noticeable. So, I think, along the muscle fiber, 2 centimeters, and then radially 1.5. But sorry, I don't, that's our head neck group treating them.
Okay.
Good question.
Yeah,
Let's see
in
the next
US,
one.
physicians really specialize. Okay,
Yeah.
so there's another question from Dr. Sokolowska. Dear Dr. Welliver, thank you so much for excellent lecture. I was wondering how frequently do you treat peritoneal sarcomas? What are the key principles to consider when treating this localization? And what's important in radiotherapy for it?
That's a really great question. So we didn't touch upon the retroperitoneal sarcoma in this lecture. So that also is very institution dependent, first of all. So So I think a lot of institutions don't believe in radiation. So as you know, when you're radiating in the abdomen, if you remove the tumor, then the bowel falls into place. So we almost never recommend post-op radiation. So first of all, no post-op. So then, the question is no radiation versus pre-op. So the question about pre-op was answered or attempted to be answered by Strauss trial. That was a European trial. Then they showed, um, no difference in local control. It's the intra-abdominal recurrence survival. So that's the endpoint they use. So that there's a lot of flaws of that study. So some institutions don't believe in the results of that because you could have the tumor in one area of the abdomen or retroperitoneum, but then if they had, liposarcoma can be multifocal. So then you have a recurrence in the opposite quadrant of the abdomen. They count that as a failure after radiation. As you can see, that's not really fair. So, some institutions still do pre-op radiation because they don't believe in the trial of the Strauss trial. But then a lot of the institutions, because of the Strauss trial, they say, oh, there's no role of radiation. So it's controversial. Good question. But even in that study, they showed the greatest benefits from patients with well-differentiated liposarcoma. So, for all institutions, if they have retroperitoneal sarcoma with liposarcoma etiology, well-diff especially, they still would recommend pre-op radiation. So that's an excellent question. And then in terms of margins, so obviously you can't do the same margins as the other one. I go with Dr. Delaney's approach recommendation. So GTV is the tumor itself, and then you expand 1.5 centimeters for your CTV, and then they have a posterior margin boost that's integrated into that CTV. So that's your CTV2. So to make sure that the high risk margin is boosted at a time of pre-op radiation. So that goes to 63 gray. Whereas the tumor is contacting the bowel, that's usually can only get less than 50 gray because that's there's about constraints there.
Very nice. Thank you so much. I would like to invite people to maybe turn on the microphones and ask questions if you have any. So there's a lot of questions, there are a lot of thank yous. in the
Oh,
chat.
thank you
Yeah.
so much.
Mm-hmm.
We want to just say how much we, American people still love you very, very much. We were supportive of all of your endeavor. Thank you for taking care of patients even at this difficult time.
Yeah, thank you. Thank you for saying these important words right now for Ukrainians.
Mhm.
They are a little bit disappointed what's happening from US, but we'll try to support them as much as we can. And many, many Americans support Ukraine. So, Dr. Shepil, you wanted to ask a question?
Yes, thank you very much for very interesting lectures, very important for us in our practice. And thank you for support American people. We understand all situation and we believe that we live together in a peaceful world and treat our patient together.
Yes, absolutely.
Yes, and I have some maybe same questions about retroperitoneal sarcomas. If we have gigantic tumor, for example, we have not opportunity do preoperative treatment because it's very big volume. And
Mhm.
for example, after operation treatment, we have R1 resection.
Mhm.
What our tactic with radiation therapy after this? What do you think about this question?
Yeah, so if they already operated in R1 or even R2 resection, I usually recommend for them to observe if the tumor return, then do pre-op at that time, rather than give post-op radiation because the toxicity is so high when you have the bowel and stomach and duodenum right all there. So that's been our approach here at Mayo. But I know that's done and show post-op radiation can be helpful in the meta-analysis. So it's not wrong, but it's a very controversial topic, I think. Yeah.
Yes, thank you very much. I also think about this, that it's a very controversial topic when we have
Mhm.
R1 or R2 resection and
Right.
don't do anything in this time.
Right. And
It will
also there
be
are unresectable tumors too. And that can, the tumor can grow very much larger than, say, the head and neck sarcomas or extremity. So then what do you do? So what is a treatment approach for that? So, some people just do palliative radiation. Some people go higher. We sometimes do grid,
Yeah,
followed by palliative radiation.
it's spatially fractionated radiotherapy.
Yeah, especially fractionated radiation, where you give the, kind of a non-homogeneous dose to the tumor, and then followed by some dose. I mean, that's like really variable. We're talking about doses all over the place.
Yeah, actually, Mayo is one of the leaders in the US on spatially fractionated radiotherapy, right? Do you currently have any clinical trials enrolling patients?
We have we're currently we have one that's going to be active.
Okay.
But
That's great.
but it's been basically used without
Mm-hmm.
really a lot of data, right? We
Got it.
we have a publication on a retrospective studies on that, but it's really hard to tell because some people use 15 fractions. That's
Right.
similar with the imaging results, because when you don't have resection, you really can't tell the results of that. Australia has recently published a small cohort of patients where they treated with 5-fraction radiotherapy, where they did inner boost to 50 gray. It's really high dose, but to a smaller volume, and then the whole tumor is getting 20 gray. So they claim the results is really good. But those are the things people are exploring. That obviously is not, it's a hard topic for, for many, because a lot of times it's not resectable anymore by the time they present to us. Yeah.
Yeah, thank you.
Thank
Thank
you.
you for
Thank
that.
you very much.
And
You're very welcome.
Serhi, you have a question? Dr. Brovchuk?
Thank you very much for the presentation.
You're very welcome.
I also see my colleague here, medical physicist, and we actually did have what we call paired cases. So he asked me about this localization, and then we also had this very similar patient. So the localization that you showed, when there is a we call it Superman position, or when you place the extremity that is kind of more or less good for position of the patient. But we had also the patient when the localization was his shoulder, and also we see a surgical scar somewhere lower on the lymph nodes, and also it was on the inner part of his hand. So in that case, when the patient is put his arm up, so it's right on the area where the head is, and also can you comment on the position of such patients?
Yeah, the
a good
shoulder
question.
and the arm is hard, right? So that we have extremity board where they do the, that mask, where they show that hand is a distal limb. We also have, the extremity board, you can make a mask of the shoulder. So then you can have the shoulder sort of like a akimbo position, the shoulder being away from the body. So it's not touching the body wall, and it's not up like this, because then, like you said, the head is going to get radiation dose. But the hard part is that sometimes it doesn't fit the scanner, right? Especially as a big patient. So that's just, that's why in the lecture I said, you need to go to the sim. I mean, the physician needs to be there. We sometimes have to try different positions. Sometimes the extremity board won't work. Then you try the back lock, the vacuum mattress, small ones, big ones. Sometimes we have to use a few just to see what would fit. Because when it's so offset, then you also can't. The problem is that if it's offset, the imaging quality is really poor, and then you lose the sight of a tumor. So that could be also bad.
Yes.
So I would say this is a lot harder than, say, rectal or prostate cancer treatments, right? And it's very individualized. So
Yeah. Thank you very much. Thank you very much
yeah,
for
you're very welcome.
Thank you. And maybe I'll ask one more question. When you were presenting about the epidemiology and risk factors, and you mentioned exposure to chemicals, and I kept thinking about Ukraine and war in Ukraine, and also trauma and so forth. So that can be a cause for sarcomas. Have there been any studies showing how the increased risk of soldiers getting sarcoma?
I
What has
haven't
been?
seen that study. I think that would be a good study to do. Because the problem is the lag time. There's now we have friends who from Greece and from Europe that developed thyroid cancers from the Chernobyl event.
Sure.
That's many, many years ago. So
Latency is
yeah, latency.
but I
So you
was
probably
wondering,
see
maybe
that.
Vietnam War, right? So there must be some data.
Yeah. So they show that Agent Orange, for instance, is
Okay.
connected, but um, I think some of the epidemiology work was not necessarily encouraged just because of financial reasons.
Especially now. Okay. Yeah,
So that,
it's a sore
I've seen,
topic.
the veterans here
Mm,
trying to fight in order to get their benefit from Agent
yeah.
Orange exposure, or submarine, that has a nuclear
Right.
that has nuclear exposure, like radiation exposure from the submarine. Um, Yeah, so for sure, it's going to be impacted, and also delay of care, right? So we know
Right. Yeah.
how COVID played a role in that, and not let alone a war here. So
Yeah.
that all of that would play in a factor for cancer care.
Yeah.
Yeah.
Thank you so much for such a great lecture. I would like to ask if people can turn on their cameras. We'll take a photo with Dr. Welliver and
That
send
would be
her
great.
for a memory.
Yeah, that would be awesome. Thank you so much, everybody.
And thank you for taking your time, preparing the lecture and teaching us, answering our questions. It's very
You're very
important
welcome.
for support for Ukraine. Thank you.
Yes.
See how
The
beautiful
honored.
Ukrainians are?
Yes.
It's late time and they are still with us and listening. Okay, I'm gonna try to capture this. Okay, smile. All right, great. Thank you. Дуже
Thank
дякую.
you, everybody.
Yeah, thank you. Thank you. Have a good evening. Have a good night. Тримайтеся. Слава Україні. Thank you,
Героям
Dr.
слава.
Welliver.
Героям слава.
Mhm.
Thank you,
Bye
Dr.
bye.
Zaluska. Bye-bye.